This is one of the most important session on Cataract, that is a national symposium, and we have got the best of the talent in the country who will be speaking over here. So first speaker is Dr. Chakravarti. As you all know, he is internationally acclaimed cataract surgeon, has written a lot of books, and so we'll be listening to him. He will be talking about cutting edge technology in IOL calculation. And I think this is one of the very, very important topics, because the cataract surgery has become much more simpler with the advent of the better equipment, that most of the patients are unhappy if the biometry is not correct, if the IOL power calculation is not correct.
Is Dr. Vedan Prakash around? I haven't seen him in the conference. Okay. You're next. Okay. Yeah, Dr. Arif.
We will have a good discussion if you finish in 8 minutes, otherwise you can take a little more. 48 minutes.
Okay, you can take 10 minutes, I think, Arif, because there are...
No, I'll try to finish it very possible.
Yeah, okay, fine.
Everybody can take 10 minutes. There is no problem, because there are only 6 speakers and we have got 3 minutes. And we have 5 minutes, so.
Okay, yes, start.
So, good morning, friends, and thank you, Scientific Committee AIOC for giving me the honor to talk on this platform. I have been allotted a very interesting and loaded topic, cutting-edge technology in IOL calculations. We all know today cataract surgery is a refractive surgery, and with the advent of cutting-edge instruments, the current formulas and lens constant optimization, the visual outcomes have become truly outstanding. Using swept-source OCT-based optical biometers and current formulas, we can expect 88% to 90.6% of our post-op patients to land within a refractive error, prediction error of 0.5 diopters. So this is really astounding. We also should realize that IOL calculations is a very happening and dynamic field. No sooner than we have settled down on an IOL calculation practice pattern with the cutting-edge biometer and the current formulas of the day and reached a zone of comfort, the news percolates that there are new software upgrades, there are new biometers that are available in the market, and we need to really be alive to such an eventuality. How do we face this kind of situation? Now, for example, the last couple of years we have seen the advent of IOL Master 700 and the Argos, but recently we have had the Heidelberg Anteron and the Hatchfate iStar 900, which is going to be shortly released in the market. So how do we tackle this situation? So I'm going to give you my perspective as to how you should incorporate newer technology in your practice pattern with the goal of giving a very good post-operative refractive outcome. Does it mean all these advances and newer devices that come into the market, does it mean that all these old generation OCT, the optical biometers, they go into the oblivion and you get rid of them? My answer to that is a big no. I would like to quote a study comparing Aladdin and Lenstar, which concluded that both the machines had a high level of repeatability and agreement. And the same logic or outcomes can be extrapolated to include the other optical biometers which we have been using for the last so many years. IOL Master was soon replaced, or rather supplanted by IOL Master 700. So should we all upgrade to IOL Master 700? So this article in BJO 2015 compared the performance and showed that there is tremendous or excellent agreement between these two devices. Yes, IOL Master 700 has certain advantages because it is swept-source OCT-based device. So it is more effective in obtaining biometric measurements in eyes with thick pushless subcapsular cataract and dense nuclear cataracts. It has also certain advantages, certain features which are not really so common in our day-to-day cataract practice. For example, the tilted lens and then diagnosis of tilted crystalline lens and visualization of the macula. Like if you have a retinal OCT, there is no need for us to really visualize the macula. So I feel that if you are doing well with IL Master 500, you can definitely continue with it. So when do you consider the new biometer? So that is the thing that confronts us. So if your existing biometer is not functioning properly, there's frequent breakdowns and it has become inaccurate, it has gone out of maintenance after 10 years, then the company stops maintenance for these machines, then you have to think about a new biometer. If your biometer is aging and you are on the lookout for a new one, so that is another indication. Then some of our colleagues have a fascination for the latest and greatest technology. Any new toy in the market, they would like to acquire. So you must realize that newer options may have several refinements and technological improvements that are nice to have but are not essential. Since these come with a very high price tag, if you can afford it, there's no harm in going for these, but if you can't afford, if it doesn't suit your practice style, it is perfectly all right not to go for it at this point in time. Then again, when you have a cataract practice that is blossoming, that is growing by leaps and bounds, you require better patient control, patient flow in your practice, then perhaps it is important to think about a new biometer. So when you have decided that yes, you want to go for the biometer, new biometer, what are the parameters that you look for? I would look for the type of technology. So now most of these biometers, new 4 biometers which I mentioned, they are basically based on straight source OCT, and the other older generation optical biometers you're already familiar with. It goes without saying that new biometer should be very accurate and give us consistent measurements like the previous biometers. They should also be able to deal with very hard cataracts, posterior polar cataract and posterior subcapital cataract. It should be easy for us to integrate these new gadgets and equipment to our patient workflow. That is very important. It should not delay our patient workflow that just for a biometric we are going to spend a longer time. Many of these devices have a built-in IL calculation formula, so there is less chance for transcription errors. But I'm not a very big fan of this logic because the IL powers which are built in this machine, their lens constants are not updated frequently. On the other hand, if you go to the online lens calculators, I'll be coming to it later on, those are updated very frequently and those are more accurate than the built-in calculators which you have in these devices. And last but not the least is the price of the machine, the vendor support and the maintenance issue. You may have a very good machine, but if it is not supported by the vendor, you might as well not use this machine. Now this is, I have picked up Dr. Kumar's social media post with his permission. Now he went for a particular device and he put up why he went for this device, and I thought that was very interesting. He had an extensive demo of this device and he found out that it suits his practice because this is the only system that uses straight source OCT and ray tracing technology for all corneal measurements. He gets true readings of all corneal parameters independent of the clear field, so on and so forth. Okay. So I just went into the literature and fortunately that last month and the month before that, there are articles comparing the performance of IL Master 700 and the Anteron. And it showed that Anteron showed myopic refractive prediction errors, especially when you're using the older generation formulas. And these two straight source OCT devices could not be interchangeably used. And even if you use a OCT, optical biometer, if you don't use the validation guidelines, it is as good as not using these machines properly. We must forget about the old generation formulas and embrace the newer formulas, the formulas which belong to the current millennium. Direct Universal 2 is my go-to formula. It is freely available in the APSCRS website. The Direct suite takes care of all your IL power requirements, so you don't have to go anywhere else. And the beauty of it is it is accurate for all eyes, regardless of the axial length, extremes of axial length, very high, very long eyes or very short eyes. You don't have to modify the axial length. And it also can be used, it's a good news, for immersion A scan if you use the appropriate A constant. Hill RD formula also has been very popular. It is free in the ACRS website. It is basically entirely data-driven and based in artificial intelligence. And version 3 was released, and I have found that version 3 definitely is a definite improvement over the earlier version because it is capable of giving inbound calculations for very high power and very low power lens. Range varies from plus 34 to plus 6 diopters, as well as the meniscus design intraocular lens. And then there are new kids in the block, 10 non-toric, toric, keratoconus. I've used the Kane formula too, and I found it to be very accurate. And I found supported evidence in the literature where Kane formula has done extremely well, if not better, compared to the other formulas, while calculating for non-toric IOLs, toric IOLs, as well as in keratoconus situations. Pearl DGS calculator is again a new kid in the block. It was released a lot of fanfare recently. So it is a second eye enhancer. So till that time, when I was enhancing my second eye calculation by using a enhancement factor of 0.3 or 0.6, depending upon the IOL power, depending upon the IOL formula that I was using, whether it was the Barrett Universality or the older generation formulas. So friends, cutting-edge technology in IOL calculations are very useful because they definitely help you to keep with the times, but you must judiciously adapt to the new technologies as they present. Just use validated measurements, employ the right formulas and the recent formulas, work with properly optimized lens constants, and strive to use all available resources to the best advantage. Thank you very much for your kind attention.
Thank you, Dr. Arup, for a wonderful presentation. Are there any reasonable optical biometer available for those who can't afford these type of biometers? Cost-wise.
So there are a lot of reasons. They may not be the first source OCT-based biometers. These are the older generation biometers, and there are buying groups available today. So if many surgeons pull together and join that buying group, the price can be dropped significantly. The refurbished machines are also available. I must have 500 can be purchased at a much lower price than the newer older generation.
Any Chinese, Korean, Taiwanese biometers available?
Not that I'm aware of, sir.
Yes, so you have one by Helix, which also combined with the OCT. I was not very happy with it, but yes, you have, and that's with the OCT you can also get the IOL. Then you have with Tomy, you have with Nidec, and IOL Master 500, which is refurbished, you can get because a lot of us are upgrading.
Tomy and Nidec have been available for quite some time.
That's what I'm saying, but what he was asking was Chinese. I really don't know about Chinese, but this is Korean, I think, or Taiwanese. Helix. Jagru does that.
Once Jagru also brought to me one of the probably Chinese...
So can you speak close to the mic, sir?
So once I think Jagru brought to me one of the Chinese, whether they are selling it or not, probably they are not selling Helix. And I compared with the lenses side, was very accurate actually.
Yeah, that is
so
the advantage.
No, what I'm saying, the many in the periphery just want to have the accurate optical biometry, and these ones they cross the 20 lakhs barrier and going up to 30-35, maybe not very viable for the person sitting in a periphery. So in that case, if something is available in the range of 8 to 10 lakhs, means they can afford very comfortably and can use it.
So I'm not really sure about how reliable these Chinese products will be, because we are talking about...
So you need to compare. This is what I'm telling you. Any one of us can compare. It's very easy. Any day, in the OPD, whatever patients are there, 50 patients in the OPD, you do 50 patients on both the machines, will come to them in a day. Yes, it's reliable on it. You don't have to wait for that, whether the measurements are matching or not.
My comment will be just not the cutting edge, opposite to the cutting edge that the way we live in India and Bharat with the biometers. I can tell you that A-scan biometry, if you have very good and you do yourself, and K1, K2 you do yourself, and that is very good, then any of the formulas, old or new, in fact we are seeing that how many formulas are suggested, more the formulas, more the confusion. I was operated with trifocal. The biometry was done by 3 different machines in 3 different institutions. I still have a cylinder of 1.5. So whatever you do, you cannot tell person 100% that you would not have a cylinder, you would not have a glass. So I think everybody will agree here on panel also.
Yes, sir.
That whatever machine you use, you cannot predict 100% that you will be zero with my calculations. Thank you very much.
Sir, actually nobody claims to be zero, but what we are targeting, 85% of the patient or 90% of the patient should reach within minus 0.5.
Yes, we do the A-scan.
So the A-scan was very good to the point and time, but definitely if you can afford new biometers, there are many advantages. The accuracy is definitely better than A-scan, Secondly, it is not operator dependent. That's the another big advantage, because when you do a scan, the type of the optometrist you have and doctor doing it yourself, taking care of so many other things is very, very important. While in an optical biometer, you are not dependent upon the operator. That's the biggest plus point. So in a Dr. K.P.S. Malik may be very good doing the optical biometry, the A-scan biometry, but I doubt as head of the department how many times he used to do it himself. And if you have got to do 20 cataracts next day as HOD of the big institution, probably you won't have that time to go for a A-scan biometry.
Sir, I would agree with what Manik sir said, but I would just have to qualify his statement by mentioning immersion scan. It is not contact scan.
Okay, thank you very much. I think that's a valid point made by Arup that if a scan has to be done, then it is immersion. We will now invite Rohit. Dr. Rohit Om Prakash, as we all know, is a great surgeon and above all, I think, a very great human being. And he has a very high volume practice for cataract and refractive surgery in Amritsar and does the winter IIRSI. Rohit, over to you for multiplication machines you'll be talking about.
Thank you, Dr. Mahipal sir, for kind words. Well, I have been assigned to speak on phacoemulsification machines at cutting edge. Well, as far as the advancements in phacoemulsification machines are concerned, the basic objectives are that we have to have chamber stability, irrespective of the IOP which we are using and the fluidics which we are using. It has to be a digitally integrated surgical outflow, and the working efficiency has to be such that we have to be able to cater to all types of lenticular situations in an efficient and similar way. That is the basic objective in advancements. I'll be going through a few of the ones which I could muster from left, right and center. First of all, I would be talking about the Centurion vision system. I need to say I do not have any financial interest whatsoever with any of the machines. This uses active fluidics technology, quite contrary to the gravitational one, which is a reactionary one. It's an active one wherein it is designed to significantly reduce occlusion rate surge, uses compression plates to adjust pressure on a BSS or BSS plus irrigating solution bag, compensating for any IOP changes in the eye. So it detects and compensates to help maintain surgeon-selected IOP. So it is able to detect flow rate, irrigation pressure and vacuum, and compensate for pressure loss to help maintain your target IOP. So these are some advantages which I need not go into the detailing because they have all machines say that we do this or we do that. Another important thing which has been added to their portfolio is the active Sentry handpiece. It is probably the only one as of now. There are quite a few which are down the line, which has a built-in fluidics pressure sensor that detects pressure in real time. It doesn't go there. The handpiece itself detects pressure in real time and communicates with the Centurion vision system. It alerts active fluidics technology as fluctuation occurs in AC, triggering immediate adjustments designed to stabilize anterior chamber and ensure consistency. The next in the block is the Zeiss Quattro, which has been just launched here. Well, it has the key benefits that it provides patented Quattro pump. I will be talking about that. And it has a digitally integrated surgical workflow and automated ultrasound power on demand. So now what it does is, as far as the chamber stability is concerned, independent of intraocular pressure and flow, the fluid dynamics directly measures and synchronizingly controls infusion and aspiration in real time. The surge, according to them, is impossible to experience because the IOP recovery is in about 200 milliseconds, and pneumatic ports which control irrigation and aspiration volume. Irrigation pressure sensor monitors irrigation pressure. So the cassette has 2 infusion chambers, 2 aspiration chambers, and they have 4 ring-like chambers which work cohesively together to provide a synchronized and reciprocal exchange of fluid. The infusion leakage is automatically compensated. Well, this is another great feature which I will be trying shortly. They have one digitally integrated surgical workflow. So you have a one surgical view, microscope view is integrated on the phaco screen. Surgeon view is for everyone in the OR. Faster anticipation of upcoming surgical steps. I'll show in the next slide how it appears. So you have the Callisto eye work steps and phaco steps combined in one workflow. Full surgery control via intuitive user interface or even with the foot control panel. So easy and comfortable surgical experience. So IOL Master and Zeiss Forum is also integrated and it has a single access. Paperless timeout checks and other relevant. So this is how it appears. So this is how it connects your OR devices for more efficiency. You have a one data access, one surgical view and one sterile cockpit. It looks exciting. Then automatic ultrasound power on demand. So up to 50% less ultrasound. This, I suppose, another machine also has it, wherein it uses intelligent pump to detect pre-occlusion phase, automatic deactivation of ultrasound power on occlusion. So I think NIDEC machine also has it, and it reduces ultrasound to its absolute core. So it improves tolerability and there's a relaxed surgical experience. The next in the block is the Veritas Vision System. This is from Johnson & Johnson. So they are coming out with another new innovation, which they claim has less surge, more stability, and glide to any lens density, a difference you can feel. Now what it does is, it has an advanced tubing system, which minimizes post-occlusion. So because surge is one of the most important factors, which plays role in different situations, wherein you don't want, when you are in a tight corner, you don't want chamber instability. So that is another thing. So it has 2 peristaltic and a venturi mode. I think Signature Pro also had the same. So the post-occlusion surge is minimal, and the venturi flow rate is also there, which doesn't compromise on chamber stability. So it has an advanced infusion with pressurized infusion, adds 22 mm mercury of irrigating pressure. So it achieves equivalent bottle height up to 136 centimeters. So it deepens the anterior chamber and expands working space, helps protect intraocular distance. So it can glide to any lens density, even dense cataracts, white star technology, and the elliptical ultrasound it is using, dual pump system I've already talked about. So another important thing which has come up is the swivel handpiece, which has come up. So now this handpiece, it puts ease of maneuverability and comfort in your hands. It's lightweight. 220 degrees of rotation at the distal end of the handpiece, while the proximal end with tubing remains stationary. Ease of maneuvering within the eye is there. It reduces torque from tubing. Precise control of the tip and irrigation port in direction with fine motor control to the surgeon's control of the wrist and the arm. So basically, I think the most important thing as far as I'm concerned which has happened is, with these machines you are able to work at low IOP phacoemulsification. You can work even at IOP 20, which is 24, 26, which is near physiological. With this low IOP, you do not have, the patient has less pain. Even if you have a PCR, the possibility of your nucleus getting dropped decreases because there is less inflation of the bag, less inflow of fluid. And in myopes, what has been seen is that there is less of lens iris retropulsion syndrome. I have never seen it even in high myopes when I'm using low IOP phaco. The immense chamber stability is there. Every time when we come back, we say that is the cutting technology. And the beauty of the science is every 2 years, the bar is being raised. What was the latest becomes, outdated for
Chetnan, I now invite Dr. Maypal Sir. He'll be talking about flash today and tomorrow.
Thank you very much, Harvans. I'll be talking about flags today and tomorrow. The first part would be just a couple of videos and various situations, and then I'll be talking about what are the other advances that are happening in flags. Kanto actually, what we have looked upon is essentially as a tool for standard cataract surgery. I think that exactly is something which is important, but what we have to look at is in complicated cases that the role of this technology actually comes into view to a larger extent when we are dealing with complicated cases that we have. So one of the best things that I always work on is the posterior polar cataract, wherein the existing posterior polar cataract which is there, we have shown that the laser integrated OCT is very useful in detecting pre-existing lens. So I'll just show you one case. In this particular case, you can see even on the slit lamp, you can see that there is a huge pre-existing defect which is there. Now, if we were to do a routine phacoemulsification, we would not have a great epinuclear cushion because the hydro procedure can just blow out the capsule. So in this particular case, you can see when we are getting the OCT image, you can see that this is the area where there is a significant defect which is there, and the OCT is helping us plan the femto procedure. So when we are, you can see these three bubbles that we have. So we are raising these three bubbles to give a default setting so that we have a big epinuclear cushion that remains till the end of the surgery. So you saw that blue area, that is where the nucleotomy is going to happen. We get a round perfect capsulotomy, which is obviously going to be a big help in case you have to put the lens into the capsular bag. So this is the microscopic integrated OCT, a picture on the microscopic, and you saw that there is a huge pre-existing defect. Now what I wanted to show in this particular case was that I did not do any hydrodissection or delineation, and it was the pneumodissection at the plane that happens that we were able to, without altering the break, there is no vitreous that is presenting. You can see that this is a break. We have been able to remove the entire nucleus. Now one again and does not go right till the center when this is again the break when the cortical aspiration is done. So you start from the periphery, leave the center. You can see the huge break that is coming. Viscoelastic is always injected before you withdraw. You can see this blob of vitreous on the integrated OCT, and you can go ahead and put a 3-piece lens. So this is what I have shown. This is the slit lamp. You can also see on an IOL-700 that there is a defect in the posterior capsule. You could see that when we did the OCT on the catalyst system, this is the area we are leaving behind, that we are not doing the nuclear breaking, and this is after the completion of the irrigation aspiration, and you can see that this is a vitreous blob that is coming. So the epinucleus acts like a shield, and the pneumodissection is what is required, so you don't do any hydrodissection or delineation, and you have this airbag that you have which will protect you right till the end. We don't have any nucleus drop that I can say once I switched over to femto in posterior polar cataract. Now let us just look at rock hard cataracts. When we are looking at rock hard cataracts, you get a good capsulotomy. The capsulotomy needs to be a little bigger so that the fragments can come out, and you can see the air bubbles coming. This shows that there has been a fractionation. So you can see that the fractionation has happened pretty well even in such rock hard cataracts. So the amount of energy that we use in such rock hard cataracts definitely decreases to less than 50% of what you were using because you have a pre-chopped nucleus. Then even if you don't have the counter traction force that is available for you to do a capsular excision in cases of these subluxations, it can cut through vitreous. You will see that there will be vitreous here, and we will still get the capsulotomy coming in very well. So you see here, see the bowing of the iris. Can you see that? We can customize the capsulotomy. When the capsule is pulled back by the endocapsular ring, we can do that. And in this particular case, what I wanted to show you was that this is the vitreous here. We have got a fantastic capsulotomy which has decentered slightly, but when the ring is going to come, it is going to get centered, and you can see that we have been able to make 6 quadrants. Now we go with the pars plana approach, which you can see here. Rycod has been injected, and we are removing the vitreous so that there is a decompression of the vitreous that is there. how mobile, I would not have been able to do a capsulotomy if I didn't have the power of femto. Endocapsular ring has been inserted. Once the endocapsular ring has been inserted, this is at double speed. You can see that we are able to remove the nuclear fragments pretty well. As you can see, when you do the irrigation aspiration in such particular case, and after doing the irrigation aspiration, this is fluid is on, inject viscoelastic so that again there is an upthrust, and we put a 3-piece lens apart from the endocapsular ring to center it. So this again, you can see the power of femto in subluxated cataracts even when there was a vitreous. This is the post-traumatic case. So couple of cases I have just shown to tell you that it is not just the normal cases where you get repeatable outcomes, even with surgeons who may have variable surgical skill set. But in complex cases, you can actually use the power of phaco. And what is therefore important is that let us look at where we are and what are the new things that have come on in the phacoemulsification. So this is the future, the future. This is the 6S software which is there. So what has been done is that the Cassini, which is equivalent to a pentacam, what you take an image in the OPT is linked directly to the femto laser, and the femto laser also looks at what is the steep axis. So it is going to align the steep axis that you see in the OPD versus the steep axis, because when the patient is lying down, there is some amount of cyclotorsion. So to compensate for cyclotorsion, you have a very efficacious speedy way by just putting it on the COS6 software, which gives you the superior results. And therefore, once you know exactly where the steep axis is, then the planning is also done automatically for LRIs. So typically we do LRIs up to 1 diopter of astigmatism. So you have a direct entry of the preoperative data. There is a built-in nomogram and the radial alignment incisions that you have in these. You can see this is Donnelly formula which has been modified. So the brain damage that we were to do earlier as to how much of LRI, where to place, what to do, is taken away by having a preoperative pentacam or Cassini linked to the femto and giving you the nomogram for where you have to do. So therefore the accuracy will deliver superior results, and you can see that the outcomes are pretty good. Again, there is a software where for toric IOLs, you can now have marks on the axis where the toric IOL has to be placed. So you get 2 radial marks which are not full thickness. You can place them so that even post-operatively you can look at the alignment. Intraoperative is one thing, but you can also look at the post-operative alignment which is there. So you can see here that this is, when you have this, there are these marks which come on the cornea, and these you can make use of intraoperatively as also post-operatively. So this is another upgrade that the femto laser is getting. Now, primary posterior laser capsulotomy, which is required in pediatric cataracts, is being done, is being worked. The only thing is that the femto and the OT may be at different places, so the sterility is the only thing, and we have to future. But one important thing that this femto laser is going to do in the future is to do primary posterior capsulorhexis in pediatric cataract cases, and this is something which is very, very important and would get you better outcome. So this is therefore a future regular thing that you can do. Now the next thing that is coming is a refractive index shaping or laser-induced refractive change. You can understand that you can change post-operatively also the power of the eye by working on either the cornea or on the lens. So the femtosecond is now like you have the light ablatable lens. There are enough studies that are happening to work with the femto laser on the lens that has been implanted in the eye to take care of residual refractive errors that are there. Apart from that, there is something which is called as a laser-induced refractive index changing that can be done on the cornea, and it is with a 405 nanometer laser, and that is a potential revolution in refractive surgery. Apart from that, small femto incisions in the periphery of a normal aging lens is being used to help reduce the amount of presbyopia because it changes the curvature of the eye. So future of femto would be fusion of diagnosis and therapy. As things stand today, the Lens AR has introduced what is known as a Streamline 4. I'll just tell you that what it is. It does an OCT and a clinical picture and looks at the density of the nucleus. That means that there is an automated look at the density of the nucleus. So you can see here, this is cataract grade 1, grade 2, grade 3, grade 4, grade 5. And this is the density. It will have a pre-program which is available as to how many incisions to make, what kind of energy to be used for cracking that particular nucleus. So this is the, I think they have just been introduced. I don't have a Lens AR, but I think this is what is introduced, that it will help you decide automatically by artificial intelligence as to how much energy and how much braking you have to do. It will enable the surgeon to make so-called micro-incisions on the cornea also in pseudophakic patients in addition to or independently of the arcuate incisions, and this is possible to fine-tune the problem that maybe Dr. Malik was saying, that he has a residual astigmatism which is there. Now another way to align the toric IOLs by the use of the femto is that when you are doing a capsulotomy in the femto, on the edge of the capsule you can have a knuckle or a mark. This can help you even post-operatively, because this knuckle and the mark can be seen also in the post-operative period, and you can see whether the alignment both intraoperatively and post-operatively. So there are either getting marks on the cornea or marks on the capsule that you can have in these things. So friends, these are a couple of the things that are happening, which is the present and the future. So there is room for improvement in logistics, maybe smaller, more mobile devices that have come. Zener claims to be one mobile device where you can ship the laser, the femto cataract from one clinic to the other clinic, and have multiple users, primary posterior capsulotomy as I told you, refractive enhancements as I told you, toric alignment as I told you, as to what exactly the density of the nucleus that you need to do, and laser-induced refractive index change that you can get with the femtosecond laser. So this is something very much, I would say, over the next 3, 4, 5 years, we will have this in the femto laser platform. Thank you very much for your kind attention.
Thank you, Mehwan, for a wonderful presentation. Any questions, comments? We move on to the next topic, and that will be SICS. Dr. Abhay is not here. Anybody is representing Dr. Abhay Vaswani over here? Dr. Handipurkar? Dr. Handipurkar is not there. So now we invite one and only Dr. Tejas Malik, and he will be talking about SICS, the Indian perspective. So this is very important. On the one hand, we are going on to the flaps, simple laser assisted cataract surgery, where you can mark the toric IOL. Next slide.
Friends, introduction is that I am a Desi breed. Amongst the German, Aryan, Pomeranians, German Hound and so many. So Desi breeds last longer. I heard in Brazilian cows, which are Desi, they can survive without water for many days. But Jersey cows can't survive without water for 24 hours. So Desi breed, most of you are, and you are surviving, and I am not against the technology which is coming and doing great wonders, possibly with more precision, better results, better rehabilitation, but it comes with a cost which by and large our economy is not up to. So, like one particular thing about the stability of the chamber was often talked about cataract surgery, and that is very important, that you have surge control so you have less keratitis. But almost all cataract, hard cataract, think that antechamber maintainer is one tool which all associate surgeons must learn. Whatever techniques you are doing, that you insert the antechamber maintainer, and that gives you extra fluid to control your surge without spending millions, and that's very good. Learn it is not difficult at all. So a smaller incision gives distinct advantage to the patient and surgeon, like early rehabilitation, we know it, better intraocular pressure control, low or negligible postoperative astigmatism and complications. And SICS, being a little larger incision, you can control the pre-existing astigmatism and correct it by putting the site shape of incision, changing it. You can do it from upper nasal, you can do it lower nasal, you can do it lower temporal, upper temporal, superior, superior-temporal, inferior-temporal. So SICS gives you little distinct advantage about, and of course it is a sutureless self-incision. Incision like self-dosing course. SICS was first done in 1992 by Michael Blumenthal, and he came to India, and I saw it first time from him, and I got impressed, and I was doing phacoemulsification those days, but I shifted a lot of it to SICS, and I was impressed by the results also. So I say to every young one that you must learn both, because SICS is a bail-out procedure also when you get problem with the phaco. The low-cost, effective procedure for performing cataract surgery. The proven advantage of phaco over MSI is debatable with respect to endothelial loss, post-phaco versus SICS, or post-operative astigmatism also. It is desirable now, we say that we are advanced nation, we are the Jagat Guru or about to become Jagat Guru, that phacoemulsification is available for all but not feasible at the moment. Manual small incision cataract surgery offers similar advantage with the merits of wider applicability, less time consuming, shorter learning curve, lower cost. And MSICS can be performed in high volume due to fast technique. National Program Control of Blindness has reported almost 66 lakh cataract surgery annually, and majority of surgery, that is between 85 to 90% in this country, are small incision cataract surgery, manual small incision cataract surgery. We have reduced the ECC with sutures plenty. We were doing still in the camps and all that ECC with sutures, but ECC with sutures have gone down with the advent of SICS, and we wish that district hospital doctors and small town doctors must be trained in SICS also, and phaco machines also. I think so many district hospitals are getting phaco machines also, but problem of maintenance, non-functioning, untrained doctors, and most of the centers have gone to UP or Bihar or even Uttarakhand. These machines are non-functional. That mostly people either they don't have the components, they don't have the maintenance, so they don't work. With huge amount of avoidable blindness in cataract due to cataract surgery, majority population cannot afford cost of phacoemulsification. Though small centers, many people are doing phaco with the smaller money and putting the PMMA IUL, not the foldable. So SICS serves our country. The capital surgical rate represents the number of cataract operated per million population annually. The CSR is usually between 4,000 and 6,000 in developed countries. In the last 20 years, CSI has improved in India also to about 4,000 per million population. The Latin America and parts of Asia, the CSR range from 500 to 2,000 million. So that way, cataract-wise, of course, we are proud that we have done wonders. The places like Sitapur, Aligarh, and all those places, and their camps all over the country, up to Chinese borders where I have participated, we have really done service to the cataract patients. Of course, it is regrettable that so-called camp surgeries which are done in now Pakka buildings and Pakka OTs. When I was the program in charge, we decided to have separate OT in district hospital from the other OTs, and that was done. So now that keeps it away from the infections and improved development of this one. But still this country has got nearly 4.5% blindness because of complications of cataract surgery. That was 11% some years back, but it has come to 4% or 4.5% blindness because of so-called camp surgeries or the mass surgeries. Modification introduced many new techniques that will reduce the size. Ruiz, Nepal did something. We have introduced the anterior chamber maintainer, and even I introduced the visco through the anterior chamber maintainer to push the hardest nucleus to the tunnel, and I can take out most of the nucleus through 5.5 millimeter from incision. So this is little said that it is debatable still that I have seen but one Shakya from Chitrakoot. With light time, he showed the SICS in 2 minutes, exactly 2 minutes, up to the opening of the incision and closing of the incision, but there are rare persons like that. But you have maybe that experts sitting here, they can do the phaco in 7 minutes, 5 minutes, and they don't have effective phaco time of 2 seconds, 3 seconds. So things are different in different hands, different machines. So high volume delivery system done in large camps is average 4.5 minutes. Steps of any size, little, मैं चला देना इसको, video को. So this is a small video. Volume. So you make the incision, do the cautery sparingly, don't burn the sclera or you get myopia, and then frown incision, frown scratch, and it is since the incision is away from limbus, away from cornea, the pigmentation effect on the vertical curvature will be much less. All cataract surgery, you know, produce ATR, that is a vertical curve which is myopic become hypermetropic because it slides down. And then anterior chamber maintainer at 7 o'clock or this side 5 o'clock, it has screws and it stays there. And in hypermature white cataract, you can do the capsulorhexis without this screw, and this fluid keeps from coming out of the side port in a white cataract. And I do bimanual rhexis, that is my left hand works on the rhexis to keep it in control, doesn't allow it to go. So bimanual rhexis keeps you the desired rhexis what you want, and generally in these patients we want more than 6 millimeters, and you know the jonules come up to the 2.5 millimeters either side on the front of the lens. So you have got virtually 5 millimeter of the zone-free area, zonal. But as you go in periphery, they are more dense. So in center you can still, the chamber, the lens is delivered first in chamber, that is with proper hydrodissection. You keep on injecting to create the visco in front and behind, and then simple nudge by iris depositor, you can use the lens slide, and then an assisting needle, dial it out, 24 gauge needle, just enter the lens, push the lens back, again do the nudging, and it comes again. So this is here. This is where the nucleus has been reduced into the size by rotating, and we have got a very small kind of incision, self-healing, scleral, early to heal, then the clear corneal incision. George Waring told, and physiology tells, that clear corneal incision heals in 3 to 6 months or up to 9 months. So corneal incision of phaco will open with slightest pressure. Not true in case of SICS. So this is our surgery. Thank you so much.
I think this is one of the best fallback option. That means if anytime caught and you're not able to finish the phaco, you can enlarge the incision and can remove it. And some of the cases it may score over phaco, but by and large phaco will score over the SICS, there is no doubt about it. And considering the constraints we have in the country and training facilities available and time takes to learn the phaco, till the time all our countrymen can afford and can have the better technologies, I think this is going to survive and this is going to do a great service to the humanity and great service to the eye surgeons. So it is to be respected and valued, but of course the coming technology will definitely give superior and a faster rehabilitation. So now I invite Dr. Suhas Aldipurkar, and he will be talking about PCR and general dialysis prevention and management.
Thank you so much, sir, for this invitation. I have a very important topic. It concerns practically each of us, mostly in the beginning, but all through our cataract life. These are two things we're going to really be watchful for, careful for. Because PCR is the most common potentially sight-threatening complication during cataract surgery. It can happen more commonly when you are in training, but it can also happen to a senior. So it is rightly said an ounce of prevention is worth a pound of cure, and it holds very true for PCR. So you have to look out for what are the eye conditions that really can cause you this. A deep off-orbit, reduced visibility, shallow chamber, deep chamber, floppy iris. Now these are some of the common things which have potential, way to get you into trouble, so you have to be careful about it. So lens-related factors would be obviously posterior polar, high myop, if there is a history of intravitreal injections, if there is a history of trauma, pseudo-exfoliation, and now this is a case of posterior polar cataract. In a posterior polar cataract, all of us know that we have to be careful. So you go about it very systematically, take all the care. You don't do a classic hydrodissection. What you will do is multiple, micro jets of hydro, so that you create a hydrodelineation. And then your whole purpose is to get the endonucleus, if possible, out of the back, so that you can easily, phaco it. And accordingly, I take all the precautions, get the nucleus into the AC, and once having done that, I also remember that when my instrument is going to come out, I will not let the AC collapse, swallow up, and so when my epinucleus is taken care of, and when time comes for me to get my phaco handpiece out, I am ready with the irrigation, which goes in so that the chamber at no time collapses. And then, to be on a safer side, I am there with coaxial, and my irrigation continues to stay there, which of course is not necessary ideally, but at this moment, I slip. Till now, the piece is intact, but if it's a posterior polar, and if it has an inherent tendency for a weak capsule, in spite of completing your case, there are possibilities like this. In an anterior chamber, you have a central safe zone, you have peripheral unsafe zone. So it is better that you stay within the safe zone because in the periphery there is increased risk of PCR. So question is, when do you get it? Mostly when you are dealing with the last nuclear fragment, often during the stage of irrigation aspiration. Sometimes it could be during PC polishing. In other words, it can happen at any stage. Now this is a case where the resident is operating and everything seems to be not correct. His positioning of the phaco tip is not correct. He is in the periphery, the unsafe zone. The moment his phaco tip is unoccluded, there is a surge and you get it. So what are the cardinal signs of torn posterior capsule? You get the pupillary snap sign, which is sudden jerky pupillary constriction during hydrodissection, sudden deepening of the AC, transient movement of pupillary margin inconsistent with AC manipulation. Now this is a patient where the hydrodissection is not very vigorous or violent. Look at this. Now this is a pupillary snap sign. Not everyone would get it in his lifetime, but some in spite of taking all the care, you will get it. Another thing is this: if you watch carefully, the sudden a deepening of the AC, the unusual movement of the pupillary border, it tells you that something is not okay. Now, if you are not watchful at that time, you can land up with a real problem. The cardinal signs of torn posterior capsule could be sudden difficulty in burying into the nucleus and a tendency for the nucleus to display a vibratory or tremulous movement that you just saw, excessive tipping of one pole and the partial descent of into the anterior chamber. So the PCI management, the primary objective is the safe and thorough cleaning of vitreous and lens fragments from the anterior chamber, and the secondary objective obviously is the stable placement of intraocular lens. The management strategies could be identify the tear in the earliest, be quick with your non-dominant hand to inject visco before the main thing is taken out. Now in this case, so the first thing you do is inject viscoelastic. And what has happened here is, fortunately, the puncture has been as a punched out hole in the posterior capsule. Your viscoelastic goes in, it blocks it, and then you have to plan what you actually decide to do. Then you have a large nuclear chunk, and if you want to do emulsification, you have to somehow ensure that it is brought into the safe zone, and then you inject, because there is some vitreous disturbance, you inject some diluted triamcinolone, try to clean up the vitreous, and once you are sure that your vitreous is cleaned up, and you have to literally go to the PC capsular area to clean it, and then inject a lens, which is a lens scaffold, which has been popularized by Dr. Amar. In this case, I am using a single piece, and there would be a question in your mind as to why am I using single piece. The reason is the PC hole that I have is a punched out hole, and at the end of the case, I am sure I can get this lens into the bag. If you are not sure, and if the PC rupture is irregular, then you will probably be better off putting a three-piece lens. And next stage is to open up the pupil, because by now the pupil has come down, and try and get the lens into the bag, because your rupture, PC rupture is a circular hole in the PC, so there is no worry about that getting enlarged. Now in this case, this is a very interesting case. You notice it, and that is the time you have to stop. And what do you do now? to find space between your rexis margin and the nucleus, inject dispersive viscoelastic, then with two hands, with two instruments, try and get the nucleus out of the bag. That's the first thing you have to do because the entire nucleus needs to be managed. And after that, my 2.2 incision is enlarged to 2.8, and again a scaffold is done with a 3-piece lens. And this time the lens is kept in front of the iris because you have to get your nucleus emulsified. Sorry. I think it's stuck there. And once the lens is in place, doing phacoemulsification becomes easy because you have to do an anterior chamber phaco. And once the nucleus is managed, then you again you inject some triamcinolone and try this time to go with the cutter behind the lens and clean up, and there are chances that there will be few cortical matter that will drop in, but try and be very meticulous so that most of the cortex and most of the vitreous is cleaned up. And after that, you can always get the lens into the sulcus, and if possible, if your rexis is small and central, you can do a posterior capture. Then, of course, I don't have time. My second part was zonular dialysis. Here, the iris hooks are used as, normally they are used for pupillary expansion, but when you have a zonular dialysis, they can be used as supporting ones, and especially when you have an extreme form of zonular dialysis, to get your iris hooks into the bag is sometimes a tough job. Ideally, you use capsular hooks, but here I'm using iris hooks, but to do that, you literally have to use your a spatula to stabilize and get those. And once the first hook is in place, it's not very difficult to get the rest of them. And in this particular case, because the zonule was literally 360 degree, I have used 5, and with that you can easily do it. Now, strategy to reduce zonular stress. Yeah, I'm done. Can I take half a minute, sir? Now, this is a case of zonular dialysis in which I have created a Hoffman's pocket. You inject viscoelastic, block any possible vitreous from coming forward, and create side ports in the places where you want to put your iris hooks or capsular hooks. Try to create your rexis off-centered, and in such cases, try and do your hydrodissection as copious as possible. And once you have done it, the next thing you do is to implant endocapsular ring, which gives you 360 degree complete expansion. And now is the time for us to decide. Yeah. And this is the way you create, you bring your nino needle from outside in and use a segment to fix the bag in that and with the convexity outward, the segment is fixed in the position of maximum weakness, and once it is sutured, then you bring your implant inside, and after the implant is in, you constrict the pupil. So in conclusion, PCR can be avoided if you anticipate it and proactively take necessary steps to avoid it. Can be managed well with proper planning and sticking to details. Zonular dialysis is easily manageable when planning is proper and technique is well rehearsed. Thank you so much.
Thank you, Dr. Aldipuka, and you have seen something to learn from him that one very good point he has told is that you can insert the lens behind the nucleus. When you have PCR, take out the nucleus out towards the anterior chamber and put the lens behind. So lens will support your capsule. You can put it first on iris and then you can go on the capsule also. And capsule will be saved and you can do the low kind of a phaco in the anterior chamber with keeping bottle low height and all the parameters low. Thank you so much. Thank you so much. Now we have another great of India, Dr. Amar Agarwal. He is pocket dynamo that he does from anterior chamber to posterior chamber, does retina, does everything, LASIK, all kind of thing in cornea, all kinds of thing in anterior chamber, on the lens, everything he does. So we have versatile, and I heard like Prime Minister of India, he also works 18 hours a day. And his bedroom story, I know that he gets up at 4 a.m., leaves the bed and does academic work for many hours. So, Amar, here. Amar Agarwal, please.
Thank you very much, Dr. KPS Malik and Dr. Harbans Lal. Ladies and gentlemen, I'd like to thank Partha also for this symposium which he is conducting. So let's look at this. Subluxated cataract. This was a VIP patient who had come to me. Okay, I thought I'll get away with it. I put an endocapsular ring. I do not have at that time a Sioni ring. And you can imagine with my bad surgical hand and bad judgment, I get a drop, obviously. Now what do? First thing, I remove the endocapsular ring. The worst part was, I had told this VIP patient, I am going to make you 6'6", N6 without glasses. Imagine. Now I've got a drop nucleus on top of that. What will I do? So I've injected triamcinolone. I've taken out my endocapsular ring as you saw so that I don't get a drop ring inside. Remember I told him he'll be without glasses. Now I go in and try to remove that lens fragment with my vitrectomy system there. And you can see there, once I have removed that, the distant macula is seen. Now, at that time we have these lovely 3-piece multifocal IOLs. So I'm injecting that multifocal inside. This is the Technis multifocal. Catch the tip of the haptic, externalize it. And you can see I'm trying to do the glued IOL, as you can realize, the intrascleral haptic fixation. Catch the second haptic and externalize it. So what are we able to do, ladies and gentlemen? We are now able to create a multifocal glued IOL. Create the Gabor-Chariot's pocket. Look at the amount of haptic which is stuck. It's quite a bit. Now you can center the rings where you want it in the glued IOL. This was a patient, VIP. I suddenly got a call from one of the best surgeons in the country, who I call as the Haryana Express because of his speed of surgery, Kapil Vora. And he said, Amar, I'm sending you this case. So I saw the patient, small pupil, dilated it with iris hooks. I made my flaps, and what do I see? Again I see a multifocal IOL, but it is decentered. So you can see I fixed a Tokar AC maintainer that time. I'm holding the lens with one hand, doing my vitrectomy, because I don't want to externalize the lens without clearing all the vitreous. Now look at the handshake technique. I'm moving one hand to the other, slowly, till I catch the tip of the haptic. Once the tip is caught, the same lens we can pull out and externalize the first haptic. First haptic is out. Now I do the same handshake technique.
sends me the patient, I have to be very careful that I have to make this patient all right. Now you can see I'm creating the Chariot's pocket there, tucking it inside, and notice I've come anteriorly because it's a large eye, so there is an optic capture. Whenever you have an optic capture, ladies and gentlemen, do the single pass photopupillasty. What it will do is solves the immediately the optic capture, and in this case, being a multifocal glued IOL, I will also get another advantage where my pupil will come down and I'll get an added advantage. So simple thing is, remember the number 4, 4 times you're passing it inside. That's a simple procedure, and that completes this case. Take out the Procar AC maintainer and seal everything down. Now Yamane brought out another modification of the intrascleral haptic fixation, which is the Yamane's technique. We modified this a bit more, and I think Yamane is a great technique. Here you can see we have put in the markers there, and you can see I'm passing the needle in, and I'll show you this modification which we published in the JCRS also, where I'm catching the haptic, bringing it out, and this is the riveting flange technique. Actually, when flange technique was started by Shin Yamane, then another person from Japan brought in this technique of riveting for iodialysis, and we use the same thing. You see, what we are doing is, after the flange created, we compressed it with a needle holder. This makes the base a bit broader. Saying that, this is the handshake technique which we are using for the same Yamane technique. So whichever technique you tend to like, please go ahead and use it. We stick to the glued IOL, to be honest to you, because of the tilt. And the amount of tilt which we get in the glued IOL is really negligible. And that's why we prefer that. But if you're happy with the Yamane, please go ahead, because I think personally, the intrascleral haptic fixation is the way to go. Canabrava also has brought his technique where he's using the sutured flange. Now look at this case at the end, which I thought I'd show you, white cornea. And this was referred by one of our past presidents of AIOC, who is perhaps one of the best retinal surgeons in the country, Dr. Natarajan. He sent me this case and he said, I'm sending you this case. And when I saw this case, I was wondering, oh boy, is it good to have such friends to get such cases? So now I've made my flaps. This patient was operated 7 times. You know, this was the 7th surgery which was operated, and she wanted to commit suicide. And when Nati sent me the patient, he told me to be careful of the patient because of this reason. I couldn't see anything. You can see, so I'm catching it, that membrane which is inside. I'm trying to remove it. You can notice I'm holding it in one hand, taking the scissor and trying to cut it. You can notice my assistant is using an endolumeter from outside to help me see better. But ladies and gentlemen, if you are not seeing anything inside, don't worry. Even I am not seeing anything through that microscope, because there's nothing much to see with that cornea being so bad. But now once I removed that muck which was there, then I saw something shining inside. And you'll see that in a second just now. So there you see some glow there. And I realized this is an intraocular lens. So before I go further, my fear is I better catch that lens somewhere. And I caught it anywhere. Luckily for me, it was a 3-piece IOL. Now I didn't do my handshake technique. So you notice here, I'm transferring it from one hand to the other. I realize the visualization is very bad, but still I'm able to manage it a little bit with great difficulty and catch the tip of the haptic. Once my tip is caught, again, you see, it's caught and externalized. Now that's one thing which you have. If I have one haptic out, now I know I'm safe. Now I go into my vitrectomy, clear up the rest of the muck which is present there, and you can see me doing that. Then I finally go in and catch the second haptic. Now I can't find it anywhere. So I'm trying to see where it is and trying to catch something there, and you can see I've caught it there. Once caught there, I will now transfer it from one hand to the other. Again, watch the handshake technique. So all of you who want to do that, please remember you need 2 forceps. To get 2 glued IOL forceps, catch the tip of the haptic always. If you catch it somewhere in the middle, that haptic will break. Now once both haptics are out, see the amount of haptic externalized. It's a lot. All I do is create a debauch Chariot's pocket with a 26 gauge needle, tuck it inside. Once that is done, look at my pupil just for a completion's sake to show you in this intrascleral haptic fixation video. Here you can see I'm just closing that small. In this particular case, I'm making it multiple times. You can also do a pinhole pupillostomy so that the patient will be extremely happy and comfortable without astigmatism. Plus, in this case, you saw the cornea was very bad. So I was going to do anyway PDEC on that patient. The advantage would have been obviously the simple fact, because of that, I will have a small pupil so the air will not go back. So to make the long story short, you can see how the case is at the end of it. The final thing was just removing a little bit of the desmoid membrane which was present. Most of it I had already removed to check it, put in air, create the PDEC bubble, and you can see the air remaining in the anterior chamber. Here you can see the final clipping which I'm going to just show you in a second, where I'm just removing that, creating the PDEC bubble. We don't do DSEX, we don't do DMEX, we do only PDEC in our centers. Here you can see the PDEC bubble, which is the type 1 bubble, which I'm not covering, just on a completion shake to show you in this video. At the end of the day, the question comes, how did this patient behave? So here you can see when the graft is inside, I'm unrolling the graft, fixing it with glue, and everything gets closed. So to end this presentation, I thought I'd just end it with showing you how the case behaved at the end of the day. And you see that this was the pre-operative, remember? 6 times operated, I was operated in the 7th time. This is 15 days post-op, ladies and gentlemen. And you can see how the patient looks. And the final 45 days post-op. Thank you very much. God bless.
Thank you, Omar, for wonderful surgery. How many hours of surgery it was?
The question should have been how many days I operated.
Great, great. Amar can do anything and he teaches so well. We have Partha here, Dr. Partha, Scientific Committee Chairman. You are supposed to do counseling. If not, you can have the questions from us, anything, about anything.
So,
Precos, femtos, and poor small lesion cataract surgery.
I think we can have a discussion on premium IOL. That was another topic. Amar?
So we call it a day and leave for next session. Thank you so much. Anybody interested in premium IOL was the topic one left, and one is counseling about the cataract. Dr. Harbans can answer few things. And in 5 minutes, we have 5 minutes. So 5 minutes you can ask in our ear